All right. So even up till last night, we were a little worried that nobody was going to show up today. So we're really thrilled to see so many faces in the audience here. So as Dr. Madrazo mentioned, I'm going to talk about cardiac myosin inhibitors today. And as an important disclosure here, Bristol Myers Squibb, the maker of one of these cardiac myosin inhibitors, sponsored the event. So they really, we couldn't have done this without the funding that they gave. Neither Dr. Madrazo or myself receive any direct funding, so we're going to try and talk about these in a very objective way. So what is a cardiac myosin inhibitor? So these are new. So they've only been around for about 3 or 4 years on the market. They're medications that are specifically designed to improve symptoms that are related to obstruction in hypertrophic cardiomyopathy. So these really have been a game changer in the way that we take care of people with hypertrophic cardiomyopathy. Up until these were released, we had either mild medications or surgery or alcohol septal ablation. So these have really opened the door to medicines as a real viable treatment option for folks who have obstruction. Right now, there are 2 medications that are worth talking about. The first is mavacamten or Camzyos. This is made by Bristol Myers Squibb. And the second is aficamten, made by a rival company called Cytokinetics. This one is not yet FDA approved. We will talk about it a little bit because it is anticipated to come out on the market relatively soon. So, we've talked about obstruction in HCM quite a few times at this point. Basically, obstruction happens when the thickened heart muscle interacts with that anterior leaflet of the mitral valve and obstructs blood flow as it tries to leave the heart. And the analogy that I like to use in clinic is like having a thumb over the end of a garden hose. It's not that you're not getting the blood flow, it's that the heart has to work a lot harder to push that blood out and kind of sprays all over the place. It's turbulent, that's what causes the heart murmur. And one of the things that's characteristic of obstruction is that it's dynamic. People have good days and they have bad days. Certain days that thumb covers more of the garden hose, certain days it covers a little bit less. Anything that makes the heart smaller, like being dehydrated, or the heart beat more vigorously, like if you're exercising, those things make obstruction worse and make symptoms related to obstruction worse as well. So this is really kind of an important feature of hypertrophic cardiomyopathy, is that people tend to have a little bit higher heart function than the average person. So we measure the ejection fraction, which is the percentage of blood that is leaving the heart with each heartbeat. And the higher that is, and usually, the more obstruction there is. So one question is, why do patients with hypertrophic cardiomyopathy have increased heart function? And you have to kind of zoom in with the microscope and look at the protein structures of the heart. So this is what makes up the heart muscle itself. This is the sarcomere that you've heard about. It's basically made up of alternating layers of thin and thick protein layers. And those are connected by something called myosin heads. And those can be either active or inactive. And in HCM, more of those connections are active. So it's like you have more rowers in your boat so that are connecting and pulling. And as those layers kind of move against one another, they contract more vigorously. And the idea of these myosin inhibitors is exactly that. You're inhibiting those active myosin heads from connecting the 2 layers of proteins and bringing you back into the normal range of heart function. So that's the idea behind how these medications work. So basically, they purposely lower the heart function a little bit. So cardiac myosin inhibitors purposely reduce heart function. And so here's a patient, echocardiogram, bottom chamber, the atrium is at the bottom, the ventricle is at the top, and that mitral valve is sort of swinging over and touching the septum, as you've seen in a couple of these presentations. And this patient has very high pressures in the heart. This is obstruction. Now, this is the patient after being on 5 milligrams of the mavacamten. And it might not be as obvious, but that heart squeeze is a little bit lower. Same exact heart. The thickness hasn't changed at all, but just lowering that heart function, as the heart squeezes, that channel is now open and the obstruction has been relieved. So it's very it's impressive to look as an person who reads echocardiograms. Again, same heart, slightly lower heart function, that obstruction can go right away. I don't want to bore you guys all to tears, but I think it's worth talking a little bit about some of the data that is available for kind of justifying why we use these medications. Unlike surgery and alcohol septal ablation, these medications have come out in an era where randomized trials, are really required to make a treatment, to justify a treatment that we use in patients. So this first trial that came out, this was in 2020, so 5 years ago, relatively small, 250 patients, and they either got mavacamten or they got a sugar pill, a placebo. And they followed these patients for 30 weeks. And on this chart, here we go, you can see that these on the red bar, these are patients who got the sugar pill. And on the blue bar, these are patients who got mavacamten. And the y-axis, this is obstruction, or the pressures in the heart. And you can see there really is a fundamental difference for people who are receiving these medications in the level of pressure in the heart, that degree of obstruction. So effectively reduces obstruction. And even more importantly, about 2/3 of patients on mavacamten versus on the sugar pill had improvement in their symptoms. So these are kind of a complicated plot, but basically red is mild symptoms, light blue is severe symptoms, and the kind of purplish, darker blue, that's basically no symptoms. And on the left, this is the patients getting mavacamten, and you can see that that ratio of patients with either mild symptoms or no symptoms really dramatically changes compared to baseline, compared to people getting the sugar pill, where only a small fraction of people have improvement in symptoms. So really is helpful and effective in reducing symptoms. The one thing that popped up on this trial is, as I said, these medications work by reducing the heart function. About 5% of patients in these trials had reduction in their heart function below normal, so too much. We overshot the dosing, and they had to pause their medication for a little bit because the heart function was low and we didn't want to leave them there. And of those 5% of patients, they stopped the medication, the heart function came back to normal. So this is a transient, temporary thing, but it is something that popped up on this trial that's worth talking about. We go to the next trial. This was 2 years later, the VALOR HCM trial, also looking at HCM patients with obstruction, but this was patients who were thinking about going for surgery. It's a little bit of a shorter trial. Same graph up on the right-hand corner here. Pressures in the heart, and red is the patients getting the sugar pill, blue is the patients getting the mavacamten. The pressures in the heart are coming down nicely with the mavacamten. The symptoms are improving. These are a plot of patients, basically how much their symptoms improved. Red is improved a lot, orange is improved a little bit, and yellow is no improvement at all. And more patients on the mavacamten had significant improvement in their symptoms. And then actually one of the things that's really interesting is that the percentage of patients who no longer had an indication for surgery was reduced by a substantial amount. People who were on the medication had an 80% less likely need for going to myectomy surgery. So seems great, and based on this, one more thing, they did have that same reduction in heart function, about 3%, so somewhere between 3 and 5% of patients on mavacamten had this drop in heart function that we have to keep an eye out on. Based on this, mavacamten was approved by the FDA in April of 2022. So these are, who's it approved for? These are people who have obstruction, high enough pressures in the heart, which we measure on echocardiogram, and they have symptoms despite the kind of usual first-line therapy that Dr. Madrazo talked about. So beta blockers like metoprolol or carvedilol, or calcium channel blockers like verapamil or diltiazem. And the dosages here range from 2.5, which is the low end, all the way up to 15 milligrams. And when we start somebody, we usually start somebody on 5 milligrams, which is the starting dose, and that can either go down over time or increase over time. One of the things that came out of that heart function decreases that we saw is that the FDA mandated or required that we use something called a REMS program. It's basically a safety monitoring program. And so for people who are taking mavacamten, we are obligated, and appropriately so, to monitor for that drop in heart function so that we catch it early if that happens. And so it's very complicated, but basically what this means is at the end of the day, when you start taking this medication, we monitor very closely. We get an echocardiogram, and we see you in clinic every 4 weeks for about the first 3 months, and then it starts to spread out from there every 3 to 6 months going forward. Every time we change the dose, we have to add an extra echocardiogram to make sure that the heart function doesn't drop on the increased dose. So a lot of visits. You'll get to know Dr. Madrazo and I very closely on these medications. We have been treating patients with this medication now for about 3 years. First patient was prescribed in June of 2022. There are now more than 140 patients that we see at Hopkins that are getting this medication. More than 100 of those patients have been on the medication for more than a year, so we have a lot of kind of anecdotal experience with this. And really what we've seen when we actually looked at the data is that our outcomes are very similar to what they reported in the trial. So green here is moderate symptoms, yellow is severe symptoms, blue is no or very mild symptoms. And same thing, about 2/3 of patients really get into that no symptoms or very mild symptoms sort of category. At the end of the day, about 1/3 of patients end up in that 5 milligram, about 1/3 of patients end up on a higher dose, and about 1/3 of patients end up on the low dose. So that's what you can expect. And we saw very similar rates of that drop in heart function, about 5%. So 1 in 20 patients where we'll have to stop the medication, let the heart function recover, and then restart at a lower dose like that. So pros and cons of using this medication. Pro is that it's effective. Like I said, about 2/3 of patients with kind of really debilitating symptoms from obstruction have a noticeable improvement in how they feel. There are relatively few side effects. Most of that comes from interactions with other medications, which we'll talk a little bit about. And you can avoid, a very invasive thing like a surgery or an alcohol septal ablation while doing it. Cons, there's definitely a pain in the butt factor with this. So like I said, that REMS program is very cumbersome. That's a lot of visits. So if you spend 6 months down in Florida and 6 months in Maryland, that can be hard to get all those visits in a timely way. It's only been around for 3 years on the market, and in terms of like the longest patient in the world, probably 5 years. So nobody really knows what it's like to be on this medication for 10 years. No red flags that I'm aware of, but we just don't know. It's just a data-free zone. It's expensive. So if you were to pay for this out of pocket, somewhere between $75,000 and $90,000 a year, which I couldn't afford, unless you're Bill Gates, you probably couldn't afford. So we really have to work with insurance companies and patient assistance programs to make sure that it's affordable. In the vast majority of cases, we can get it to a place where people can get it if they need it. And the other thing is that this is a lifelong medication. So basically it works for as long as you take it, and if you stop taking it, it goes back to the way it was before. Your heart goes back to the way it was before, which is good because if you have that heart function drop, we want to be able to stop the medication and have the heart function go back to normal. But it also means that we can't expect to take it for 5 years and then you're good to go. So this is sort of something you'll have to take indefinitely. And the last thing is that there are some interactions with other medications which we have to think about. We use a pharmacy team that really helps us guide patients in terms of what they can and can't take while they're taking mavacamten. I mentioned that there was a second cardiac myosin inhibitor that's coming onto the market soon. This has not been approved yet, but they do have randomized trials, large randomized trials that have kind of similar outcomes to what we saw in the mavacamten space. So their first one was Sequoia. This came out only in 2024. Same thing, sugar pill versus aficamten, about half a year's worth of follow-up, about 60% improvement in symptoms, and about 3% drop in heart function. So very, very similar results overall. Another trial, this literally came out a weekend or two ago, the MAPLE trial. This one is kind of interesting because it's aficamten versus metoprolol. So instead of adding aficamten on top of baseline treatment, it was, what if we started with aficamten? And we saw a little bit lower rate of improvement in symptoms, about 50% compared to people just getting standard baseline therapy, but also a lower rate of drops in heart function. And the rate of unacceptable side effects is much lower for aficamten or cardiac myosin inhibitors probably in general versus beta blockers and calcium channel blockers, or really beta blockers. So some optimism that maybe that second-line medication indication is going to jump to a first-line in future guidelines. Oops. Briefly mention these medications in people who don't have obstruction. Really, right now, the data suggests that they are not helpful for people who do not have obstruction. A trial was just released over the weekend. This was mavacamten versus placebo in patients who do not have obstruction, and there was really no difference in the way people felt on this medication. And there was a higher rate of drops in heart function. About 1 in 5 patients saw this. So we would not recommend mavacamten if you do not have obstruction. There is still a trial in the aficamten side of things that's not been published yet. We're kind of waiting to see what happens. I'm not super optimistic that it'll be positive, but we'll see. So, the next question is, let's say that aficamten gets approved. What are the pros and cons of aficamten versus mavacamten? And this is hard because there's not going to be any direct head-to-head comparisons. Biggest difference right now is that mavacamten is FDA approved, whereas aficamten is not. So at Hopkins, we're only prescribing mavacamten, at least at the moment. Improvement in symptoms, probably similar. If you look at the trial rates, maybe slightly higher improvement in symptoms with mavacamten, but again, these are slightly different populations, so it's not an apples to apples type of comparison. The rate of heart function drop may be a little bit lower with aficamten, but again, same sort of grain of salt there, not the same group of patients. REMS program, that's the pain in the butt factor. Mavacamten for sure has it. We kind of expect aficamten to have the same thing, but we just don't know until they get approved by the FDA. Drug-drug interactions, aficamten may have less of those, which might make it a better choice for people who have complicated medical regimens, like people with HIV or people who have had cancer treatment or other things like that prior transplant. We may choose aficamten in those patients. Slower to get up to speed with mavacamten. It takes longer for the medication to reach its kind of effective dose compared to aficamten. Pros and cons to that as well. If you miss a dose of mavacamten, you're less likely to kind of bounce back quickly, but it takes longer to get you feeling better on mavacamten probably than aficamten. And then cost. We really don't know what aficamten is going to cost at the end of the day, and useful in non-obstructive patients. Mavacamten definitely not. Aficamten probably not, but unclear at this point. Other things that I get asked in clinic quite a bit are, do these medications change how my heart looks? Does it change the thickness of the heart over time? And the answer is maybe a little bit. They've done actual kind of sub-analyses of those patients in the trials who had MRI, both prior to starting the medication and after being on the medication for a while. And what we see is that the heart wall looks at least a little bit thinner, maybe 2 or 3 millimeters, and maybe the mass of the heart has decreased a little bit. These are imaging. It's not like they put the heart on a scale and weigh it, so it can be a little bit hard to interpret exactly. But we've seen that in clinic a little bit as well. So this is a patient on the left that's before starting the mavacamten, and this is a patient on the right after 2 years of being on that medication. And if you do the measurements of the heart, it actually does look a little bit different, where the heart thickness has decreased a little bit. So hard to say what the clinical significance of that is. What would happen if you stopped the mavacamten in that patient whose heart was thinner? Would it snap back to the way it looked before? Just don't know. Last thing, cardiac myosin inhibitors in pregnancy. This is all based on animal studies. They looked at this in cats, and there was fetal toxicity, so we really do not recommend using mavacamten in people who are pregnant or thinking about becoming pregnant. Mavacamten can also interact and decrease the effectiveness of certain birth control methods, so really maybe not the best choice in people who are of that age and gender. And unclear if it's safe in breastfeeding or not. But this is being watched in a trial. So long story short, cardiac myosin inhibitors are really, again, a game changer in terms of how we take care of patients with hypertrophic cardiomyopathy, really an important option for people when they're deciding on what they want to do when they have symptoms. It does improve quality of life, not quantity of life. So this is all about controlling symptoms, not about extending how long you're going to live. And with people who take cardiac myosin inhibitors, about 2/3 should expect a noticeable improvement in how they're feeling. It does have a pain in the butt factor. A lot of echocardiograms, a lot of visits to the clinic, very strict timing on those that can be a little bit difficult to navigate. And then the last thing is that these medications are lifelong and that they are not safe to use in pregnancy. So that's it. Well, thank you very much, guys.